The topic of today's event is Hospice Care Unveiled, understanding what it is and isn't for AML patients. Hospice care is often misunderstood. What does it really mean for acute myeloid leukemia patients? How hospice decisions are made? What factors doctors consider and how it can support quality of life? Dr. Janet Abrahm, a leading expert in supportive and palliative care, will walk us through informed choices. At the end of today's event, I will provide my email address. If you have any topic you would like to see us cover, please reach out to me so we can get it on a schedule. And let me just take a moment to introduce our amazing speaker. I'm so excited to have her here with us, Dr. Janet Abrahm. She is a professor of medicine at Harvard Medical School and institute physician at Dana-Farber Cancer Institute, specializing in palliative care at Brigham and Women's Hospital. After 2 decades as an hematologist-oncologist, she founded the first palliative care service and fellowship at Dana-Farber and Brigham and Women's Hospital. She has been a leader in national and international palliative care education with over 150 publications, including her book, Comprehensive Guide to Supportive and Palliative Care for Patients with Cancer. Dr. Abraham has received numerous accolades, including ASCO's 2024 Walter Cancer Foundation Supportive Oncology Award for her contributions to supportive and palliative oncology care. Now you can see why I'm so excited to have her here. So now I turn the time to you, Dr. Abraham.
Hello, everybody. Very happy to be here and to speak to this question of yours, which is one that is often not really well covered in the general care of patients with acute leukemia. So I'm very happy to do this. Just to mention that I practiced hematology oncology for 20 years before there was such a field as palliative care. And so I have a particular place in my heart for all of you and your caregivers and loved ones. I'll start sharing my slides now.
Thank you.
Okay. Are you able to see that? Great.
Yes.
So I titled this slide Options because that's what I want to discuss. What are your options if you have AML? And I'm so interested that you're interested in just learning about these options at least. At Dana-Farber, the doctors there and nurse practitioners continue with all of our leukemia patients, the ones that are cured, the ones that are undergoing transplant, the ones that are going supportive therapy, and the ones who choose hospice care. So we're very lucky in that none of our patients or families ever need to feel abandoned by any of the choices they make. Their team is there for them the whole way. So I'm very happy to explain all the different options that you have. This is what our book looks like, in case you're interested. It's written for clinicians, but many non-clinicians have found it very helpful. It's written in pretty good regular English. So I made up a patient. I'll call her Pamela. Pamela has been through about all the treatments a person can go through, and she has a lot of questions now. She has AML that is no longer responding to the usual treatments, but she is on medication that keeps her counts down, and she is hoping to maybe be considered for an experimental therapy, should one come along. So she's very closely followed. She receives routine transfusions to support her along with the medications. Unfortunately, time is shorter than she hopes. So she's looking for a partner for her and her loved ones and for her oncology team to help them through this next phase, however long that is. The palliative care resources available include pain and symptom management, communication, end of life and bereavement, and then care for special issues like religious concerns or LGBTQ care or care of people who are very religious in a variety of faiths. What I'm showing you here is our website, which is simply my name, www.janetabram.com. And we have resources in all these areas. They're for oncologists and other oncology clinicians, but you might find them useful as well. And the spectrum of palliative care resources go from the diagnosis of a terminal illness on, or any serious illness. At Dana-Farber, we share our palliative care resources with any of the cancer patients. There might be a patient with head and neck cancer, for example, not in your situation, but a patient with head and neck cancer who has a lot of pain. Well, they'll get a palliative care specialist to partner with them to deal with the pain, as long as they also are dealing with the symptoms of the cancer. For AML, the people in Boston at Mass General have shown actually that partnering with palliative care during a stem cell transplant for patients with AML improves their quality of life, decreases anxiety and depression, and even at 6 months out, decreases PTSD from the stem cell process. They're now in the process of trying to see how they can expand the palliative care involvement nationally by teaching the hematologists how to do some of the palliative care things that we do and comparing that to, for example, I'm involved in the study where I saw last week a couple of patients with AML who've enrolled in the study and who get palliative care visits every time they come in the hospital, be it for FNN, for treatment, whatever, so that they have one of us in their journey from the beginning. So you may have misunderstood that palliative care was only when you give up all other sorts of treatment. I wanted to make it clear that palliative care is there for you from the beginning. And if you're lucky enough to have those resources at your institution and you are undergoing these therapies, ask for a palliative care partner for your oncologist. We've changed the name in many cases to supportive oncology because that is more clear about what we're really doing. Our department at Dana-Farber, for example, is now called the Department of Supportive Oncology. And I think there's some data that suggests that people will refer to us sooner. So what's in a name? Whatever it is, it's fine with me. But these are all the areas. Do you need help with your pain? If you need help communicating with your clinicians, any of these areas, we can help. Now, because we are talking about Pamela and her options being limited, what should she tell her oncology team? I know you're used to telling them your fevers, your counts, how much you're eating, how much you're exercising, how much you're sleeping. That's nice. But at this point, they need to know your hopes. They really need to know what you're hoping for. Of course, you're hoping for that next phase 1 trial. Anybody would. But what else? Is there a graduation you're hoping to get to? Is there a wedding? Is there a family milestone like someone's 30th birthday? What are the things in your life that your healthcare team needs to know about that you might not have shared before? Most people share with a nurse practitioner or with the infusion nurse these kinds of things. They tell them their real hopes. But your oncologist needs to know too, because your oncologist at this point can tailor treatments around those goals. It's not like the beginning where you had to fit in the box of the treatment. Of course you did. But towards the end, the treatment can fit around you and the things that are most important to you. But if your doctor doesn't know what those are, they'll just go ahead with their own agendas. I know that they want to know. And of course, you also have to tell them your worries. Not just about the leukemia, but Maybe you need help with a young child who's acting out at school. Maybe you really need social work help to sort out issues in your family that just the family isn't able to sort out. Maybe you're worried about having more treatment and the side effects, but you don't want to risk offending your oncology team. When I was an oncologist, people told everybody else but me when they wanted to stop. You'd think I'm kind of a nice person. I have an open face. They would tell me, no. They said, but you've tried so hard. We don't want to let you down by not taking a treatment. And it was other doctors that had to tell me. They said, Janet, he's exhausted. He's not any counts for ages. He's done. Well, why hasn't he told me? Because he doesn't want to hurt your feelings. He doesn't want to let you down. Your oncologists are like I was. You won't let them down by telling them what you're afraid of, even if it is more treatment. They will feel that they failed you, probably, which may be one of the reasons they haven't brought up the things we're going to talk about. Because oncologists really feel that you went into this with them and they're going to get you out of it no matter how. And so, if anything, that look on their face is not anger at you, it's grief. It's a feeling that they failed you. So when you thank them for everything they've done, it's really a gift. So please, if your disease is somewhat advanced and you're looking for phase 1 trials, spend some of that visit telling them your hopes, telling them your fears, so that you can craft a treatment plan that really works for you and your family. Then you have to decide, what do you want to ask your oncology team? And that's kind of hard. Because usually you've asked about side effects or how long the treatment will take or how many labs you need to get. But at this point, you actually might need to ask how long you have, if that's important to you. They may not have the language for this if they don't have a palliative care team helping them. But what we would do is ask the oncologist, so what's the best case scenario for Pamela in terms of months to years, even weeks? What's the worst case? What's the likely case? So that when we go into a family meeting with the oncologist, we have a sense of what the shape is of how long someone has. What we don't want is for them to tell you something in the room that they tell, and to have us hear something different outside the room. Because that's not going to help you make your plans. If you're at a place in your life where you need to know how long you have, if it's a matter of months or years, maybe a few years is nowhere near enough for a young patient, nowhere near enough for Pamela. But by asking your oncologist, they'll realize that you're ready for that information. And they have to give you an honest answer, as hard as that is for them. Generally, I wouldn't do this alone. I would have those you love there to support you. I'd have a social worker if you've had a relationship with one, or even your infusion nurse, whoever is closest to you. When you decide, okay, at this visit, we're going to ask the doctor, we as a family are going to ask the doctor this question, because we have plans to make. Should we buy that new house or not? Should we plan for a vacation in 6 months or not? One family I had said, I was so glad the doctor told me, because my mom and I went to New York and had a wonderful time while she was still feeling well. And if the doctor hadn't shared with us that time was shorter than we hoped, we would have lost that opportunity. So those are opportunities, not just sad things, that can happen when you ask, how long do I have? Because what your doctor really wants to provide you is quality of life if you are at the end of life. Comfort, a sense of control and dignity, relieving the burden on your loved ones, and strengthening and completing relationships. If you don't know that time could be shorter than you hoped, how are you going to get this done? You're not. And this is what patients said just like in your organization where patients feed in the things that they want to know about. This is patient data. This is what they wanted when time was shorter than they hoped. But these things take time, and you'll need time to accomplish them, so you need to know. So if time is a matter of months to a year or around, I'm just being hypothetical, I think you wanted to know what your home care options would be and what the difference is between palliative home care and hospice. What services are offered, and will your oncology team stay involved? As I said at Dana-Farber, the oncology team stays involved no matter what. It's important to know, though, if your own oncology team will stay involved, but I think most of them will. So palliative home care services. You get nursing services. They come, as you probably already have them. You have probably experienced, if you're on TPN, you've experienced the TPN nurses coming and checking you out. If you've been homebound after an admission for fever and neutropenia or for bleeding or for a fungal infection, something like that, you've probably had a visiting nurse service. And as you know, that's just a nurse. They come and they visit you, they take your blood pressure, but there's no social worker involved. They'll draw labs, you're eligible for transfusions. All of this are part of your regular palliative home care services. And they could be many VNAs, visiting nurse associations, have a palliative service. What can be helpful is they can be more expert in treating your symptoms than the regular visiting nurse. So if you've only had a regular visiting nurse, but you have pain now or nausea, diarrhea, maybe even a little confusion, I'd ask for a palliative home care service because they can address those symptoms in a very sophisticated way. And they'll call your doctor or your NP, they'll call your onc team and say, you know, this is what's going on with her today. Could we increase the opioids? Or she's short of breath. Could we use the opioids she has for pain? Could we use that for her shortness of breath? They'll give suggestions about symptom management to your oncology team, and they'll be eyes and ears for your oncology team. Very, very valuable. So your oncologists may not know that there's a palliative home care service, but there's usually a care manager in your oncology department or in the institute that you go to. You can ask them, could you find us a palliative home care service, not just a regular home care service? And they'll often provide social work to the home as well. So it's definitely worth investigating. Sometimes your doctors are resistant, though, to referring you to palliative care because they think they might send the wrong message because they don't understand that it's from diagnosis on. Or maybe in the community you're in, palliative care is only reserved for people who don't get treatment. I don't know. I hope that's not the case anymore. Every hospital almost in this country that has over 300 beds now has a palliative care service, which is pretty amazing. We just became a specialty in 2006. So we've only been around for 20 years. But if you are part of a hospital system that has more than 300 beds in your main hospital, you can definitely find out if you could have a palliative care referral. And most of them have outpatient services. We have huge outpatient services that include social work as well as physicians. And what we will do is meet you the same day you either have your infusion or meet your oncology team. The whole idea is not that it's just for patients who are stopping treatment. It's to get you through treatment. So we'll be there for you as you see your oncologist. And we can also help you not just with symptoms, but if you're at that place where you're not sure the next phase 1 trial is the right thing for you, and you want a neutral broker to talk it over with, because you don't want to disappoint your oncologist either. In fact, you may want to be the number one person that they choose for that phase 1 trial. And I hope you are, if that's what you want. But what if the burden of that treatment might be greater than the benefit? You might want to discuss that with your palliative care team. We're very good at that. We'll go over your goals and your hopes. We'll go over your worries. We'll help you sort out, would that treatment meet your goals and get you to the place you want to get, or actually have so many side effects that you'd be in the hospital more than you'd be at home. We're very good neutral brokers, and we will share that information with your oncologist because maybe they are worried that the new treatment would shorten your life, not extend it, but they don't want to burden you with that. But if we tell them, we've been talking about that with Pamela, and Pamela really isn't sure that the next time she wants to risk spending in the hospital. So maybe if she knows that you're going to be there for her, that would help. And the oncologist is always shocked, like, why wouldn't I be there for her? Why wouldn't I keep seeing her? And I say, well, because some patients think that their ticket to you, because you're so busy, is a treatment or a hope of a treatment. And they're worried if they decide to opt out of treatment, they'll lose you. And you're so important to them. I said, could you just tell them at your next visit that you'll always be there for them? Doesn't matter if they have a treatment or not. That's not what this relationship is about. Those things come up. You wouldn't believe how often when I'm meeting with oncology patients and their families and the oncologist. I'll tell them ahead of time, the oncologist. And then the oncologist say, you choose treatment or not, I'm there. We're there. You can't get rid of us. And the patient and family are so relieved. They're like, really? The oncologist afterwards is like, I feel so bad that they thought I would abandon them. So palliative care is like a bridge, a conversation bridge that opens up. It's kind of like having a teenage kid, you know, where the mom is the bridge between dad and the teenage boy. And somebody has to say, well, dad meant this and he meant that. And think of palliative care as that kind of relationship. We're there to make your hopes and fears known to the oncology team. We're very good at that. Now let's talk about hospice care because that's what you asked me to talk about. So hospice eligibility, if your prognosis with the disease is 6 months or less, and your doctor certifies that, then you're eligible for hospice care. But in this country, the median time people spend on hospice is only 3 weeks. And part of this is because nobody wants to talk about the fact that time might be as short as 6 months. That's a pretty hard thing to talk about. But in your case, in the case of patients with leukemia, it's more complicated than that. It's much more complicated. So the hospice services, just to take a step back, the orange is home care services. So hospice is mostly in either your home or patients who live in nursing homes. That's considered a home. So 80% of hospice care is delivered in a home, a little bit in assisted living, and a very little bit in a hospice facility. So again, some people think of hospice as a place. It's not. It's a very sophisticated home care service with a lot of people providing the care. But who does the care? The hospice aide is there about 2 hours a day. So if you're living alone or if you don't have caregivers, hospice care might be hard for you. I mean, it might help. And certainly hospice cares for people who live alone. But just so you know, they don't provide 24/7 in-person care. They do provide an aide to help change sheets and clean somebody up for 2 hours a day. And they're available 24/7 on the phone for symptom management so that the family can call at any time for symptom management. Now, the services include your own physician, as well as a hospice physician. There's a multidisciplinary team. There are aides. I'm sorry, let me go back. There are aides, there are nurses, there are pharmacists. There are usually not physical therapists. Physical therapists are usually part of home care teams, but not hospice teams. And there's a chaplain, if you wish. The usual visits are once or twice a week from the nurse, once every other week or so from the social worker. So I said daily from the aide. All hospices have to provide volunteer services too, so that if you wanted a few hours as a caregiver to go shop or go to the beauty parlor or go swimming or take a run, they will look for a volunteer who will sit with your loved one for those hours. They're required to do that. And they're also required every month to offer to send your loved one to a nursing facility for up to 5 days so that the family gets a break. Happy to answer more questions about that. They provide all the treatment needed for your terminal illness, but not not chemotherapy. So if you're on Hydrea, or if you're on venetoclax, or if you're on something that is keeping your counts down, they won't pay for that. They'll provide oxygen. They'll provide, as I said, a lot of communication. They'll provide durable medical equipment like hospital beds. And they're really there for your mind, body, and soul. If you are at the place in your illness where you know that the specific treatments are not helping and that you want to make peace with your family, with yourself, with your faith, they will help with that. They will help put mind, body, and soul together for you. But what's not offered is transfusions or blood draws or TPN. And you may be wondering why. Why wouldn't they? They help my quality of life. Certainly transfusions do, maybe not TPN towards the end of life. Hospices get paid only $200 a day for all the things I just told you. All the medical equipment, all the people, all the oxygen, all the meds. So they can't afford TPN. It's too expensive for them. They would go broke. And same with transfusions. Now, some insurances, however, will carve out its so-called transfusions, especially for younger patients. So I've had many leukemia patients on hospice who can get transfusions. Many. You'd have to check about that. Unfortunately, you have to go to the hospital to get the transfusion, which isn't great. And I don't know who pays for the transportation. But I definitely would ask about that because it's really important, especially platelet transfusions. That usually is very important. So the barriers to hospice care, believe it or not, can sometimes include your medical team. Because maybe if you haven't brought it up, they may not want to talk to you too much about what your prognosis is. They may not want to think about it because they care about you so much. And they may not want to talk about the benefits and burdens of therapy because they feel, as I told you, that in a way they've let you down, they failed you. So for them to say, yeah, I guess you do, I wouldn't be surprised if I heard 6 months from now that you'd passed. I wouldn't be surprised. That's the way we ask that question. Would you be surprised to hear that Pamela had passed 6 months from now? And if they say yes, that's a 6-month prognosis. But they may not be ready for that, even if you are. You may not be ready for lots of reasons. Your family may not be ready because they think of it as giving up. And if you speak another language besides English, there may not be language concordant caregivers. So who wants a team that doesn't even speak your language if you only speak Portuguese, you only speak Spanish? Not only, but if your language of choice, I'm sorry, if your language of choice is Spanish or Portuguese or Haitian Creole or Russian, those are the common ones where I am, some Somali languages. Why would you want a home care team that doesn't have a caregiver that speaks your language? It's better to keep with a visiting nurse who has found somebody who speaks your language. And I agree with that. That's why I'm trying to share what the benefits and burdens are of hospice care. Sometimes it's too expensive for you to pay for the medications that they won't pay for. So to sum up, sort of home-based VNA care versus home hospice care, if you choose to stay with your home-based VNA and they do palliative care, then you can get the TPN and transfusions and weekly nurse visits. And if you do palliative home care, you can usually get a social worker. If you go with home hospice care, you can get 24/7 advice, not just about symptoms, but about anything to do with what's going on in your lives about the illness. They will be focused on staying at home, whereas the nurse in the VNA, if you have a fever or something like that, is just going to say, well, go to the emergency room. The hospice nurse is going to problem solve for you to stay at home. They're going to tell you what meds to take. If there's confusion or nausea or pain, they'll tell you what meds to take and stick with you 24/7 to try to control whatever that symptom is. And even if it's a fever, they may say, along with your medical team, how about some oral antibiotics? Why don't we try those first? So they're going to do whatever they can to keep you at home. And they'll provide family support. So the visit isn't just to take your blood pressure and your pulse and see how, what you're doing. A hospice nurse's visit is, how's everything going? They'll talk to the caregivers, they'll talk to the family. They spend at least an hour usually trying to figure out. They only see about 8 people a day, if you include transport and everything, because they have so much they have to do about your psychological health, your emotional, spiritual, physical health. They have so much. How are the kids doing? Do you have a counselor at school? They're much more holistic, which can be really helpful. And by law, they provide bereavement support for your family for 13 months after. All this the insurance pays for. So if you decide either way, if you decide with hospice or not with hospice, be sure not just talk to your doctor, but to identify a healthcare proxy. Because what if you get a bad infection and you're not able to say what your choices are? Well, somebody's got to, and you don't want it kind of to default, especially if you're in a relationship that hasn't been sanctioned legally, and you really want your partner to be the one to make the decisions. It's very important to have your partner be that person in the healthcare proxy, because otherwise they might go to your parents, people who maybe don't even understand your relationship with your partner. Before gay marriage was legalized, that was happening a lot to my patients, and the parents wouldn't even let the partner see the patient because they were so mad at the partner. So I'm just speaking from my experience that it's very important to have a healthcare proxy to know what your wishes are. They need to know your hopes. They need to know your worries. And you need to fill out an advanced care directive. If you're in a phase 1 study because no effective therapies are working for you, you need to let people know there's a legal form called a POST, physician order for life-sustaining treatment, or in Massachusetts, it's called a MOST, medical order. Your proxy needs to know, do you want to be resuscitated when you do pass eventually? Do you want artificial ventilation? Do you just want to be let to pass naturally? Do you want to go back to the hospital for everything, or just if they can't control your symptoms at home? This is all something to discuss with your oncology team. And they can enter this information into your electronic health record so that if you can't speak for yourself, they'll know who your proxy is, and they'll also know what your wishes were. It kind of goes on along with, it doesn't mean anybody's giving up. We're going to do absolutely everything we can for you. But if at some point, when at some point you do pass, we'll let you pass peacefully, and the medical examiner won't have to come to your house and interfere with things. And remember about hope. This is from Reverend Gloria White Hammond. Palliative care, supportive care, even hospice care is not about abandoning hope. In the very beginning, when you have a diagnosis, you might say, I know God has healed me, or I trust that God will heal me. As you're in the middle of therapy, you might say, I hope that God will heal me. And then if the disease gets more advanced, you might, if you're a person of this kind of faith, say, God's grace is sufficient and not my will, but thine be done. Because hope changes. Hope changes from cure to quality of life to leaving a legacy. And we all, your oncology team, palliative team, hospice team, want to help you hold you in that emotional space that is so difficult when hope is changing. But we're all there for you and your caregivers. We're all there to help you make the best possible transition if a transition is needed. And towards the very end, it's really important to say these sort of things. Thank you. I love you. I forgive you. Forgive me. And at the very end, I know that you'll take care of each other. I taught you how to do that. Obviously, these are phrases for a much more complicated discussion, but these things bring closure. If you have more questions, I'm at janetabram.com. There's lots of stuff there. Please do ask Mary Lou if you have other areas you want to discuss. I don't see patients other than through Dana-Farber. So I'm a consultant to Dana-Farber oncologist. That's what our team is. But I'm certainly happy to be available. And I think we've left enough time for questions, I hope. Do you want me to stop sharing? I could do that.
Yeah. Oh, yeah. Thank you.
Sure.
I think I'm sharing already. So thank you, Dr. Abrahm, for that informative presentation. And it is time now for the discussion part of today's event. I think I already have Steve there raising a hand. Just to remind everyone that you can raise your hand, you can type questions in the chat. We're also streaming through YouTube, so you can also ask your questions there. So go away, Steve.
Hi, thank you, Dr. Abram. That was very, very helpful, very good. I coach blood cancer patients, mostly AML ones, and actually through HealthTree, which has a wonderful supportive program for doing so. And I get the question sometimes, I suppose a little over half of them have at some point said to me, "Hey, Steve, you are a longtime hospice volunteer and you're into these things here. How actually do AML patients die? How will I actually die?"
Yeah.
And I've cobbled together sort of fluffy answers. I'm not medical, that involve, could be from a pneumonia, it could be from, an infection, could be from an organ failure if you've got something weak going on. And I sort of, refer them obviously every time I get a medical question to their medical team. But I'd be curious what your general answer might be to something like that.
I think usually it is an infection because they don't have any white cells that work to fight the infection. There are rarely people who have a bleed, an internal bleed, because the platelets are so low. And then if they've had any obvious bleeds, we ask the family to provide dark sheets and towels. We even do that in the hospital. We buy dark sheets and towels to give to the patients for the nurses. Because if there's been a history of bleeding from the GI tract or something like that, or the mouth, because of the low platelets, it's just easier with dark sheets and towels. It doesn't look so scary. Sometimes I guess it's just when they don't have enough red cells. We admitted a patient with a hemoglobin of 2.9 because the family couldn't manage the death at home. They didn't want the death at home, so we admitted the patient. But people get used to low hemoglobins pretty well, and they're just very weak. So I would say it's mostly infections or bleeding.
Oh, thank you. Thank you. I just had one of my patients go from a hematoma on the brain, which was a brain bleed, and
Exactly.
had very low platelets and they've been giving him infusions of platelets really regularly. He managed to get himself in the ICU. He was full code.
Oh, unfortunately, at the end of an AML patient's life, the platelets aren't working. And I mean, the transfusions don't work anymore because of all the antibodies. We maybe have some other questions. Should we
Yep.
move on, or I don't know if I answered your question well enough.
Thank you. Very good. Thank you.
Okay.
Thank you, Steve. No worries. Yeah, we have a few that were sent. So, how does hospice care take into account a patient cultural or religious beliefs when shaping their care plan?
Ideally, the hospice nurse, as they do an intake, and the social worker will do a thorough evaluation of the cultural and religious beliefs. And the hospice will provide a chaplain if the family wants, and otherwise will work with the patient and family's own religious providers. There are some cultural beliefs that are difficult to accommodate, like putting candles around the bed, because that's a fire hazard. But they can use electric candles if the family agrees. So what they do try to do is accommodate, but certainly like facing the bed towards Mecca, or they try to find out what are the things that would make a difference. The last rites, very important. Or Sacrament of the Sick, I'm sorry, Sacrament of the Sick. As long as it's safe to do, I believe that the hospice will accommodate that and will bring in, for Orthodox religious Jews, for example, will bring in the people who need to be there to watch the body, for example, after the body dies because it can't be alone. So that's a very important part of the care. Absolutely.
Yeah, and I believe that's like it brings with what you mentioned before that it's important to have a great communication towards what you want, what it's worrying you, um so they can also provide all those tools for you, like specific tools, right?
Yes,
We
exactly.
also Awesome. I also wonder what are the biggest misconceptions about hospice care that you would like to clarify to our community?
Um, I would, number one, it would be that you have to be near death, within weeks of death, to get hospice care. Number two, that it's in a facility. You have to leave your home and go to a place that is hospice. That's a big one. That that you can't, oh, that when you're in hospice, you can't go back to the hospital. So if somebody enrolls in hospice and they get a bad infection, they go back to the hospital if they want to. They just disenroll from hospice. And then when they're back out, they re-enroll. You can't use up your hospice benefit. Thank you for asking that. So you can disenroll and re-enroll, because if you're within 6 months of the end of life and you have an infection, you still want those 6 months. You don't want to die at home of an infection. So it's not a one-way street if you enroll in hospice. You still have all your doctors, your medical team, and you still have hospital level care when you need hospital level care.
That's awesome. That actually comes to my other questions. A lot of patients, we tend to see that they believe exactly like hospice care is that and that's it. And no, like we wonder what like it's okay when patients decide later on to change their mind, and it's not a one-way route. It's just like something that it's out there that can provide patient with that support. Um, so yeah, thank you for clarifying that. And I will skip to then another question. What are some challenges families often do not anticipate when considering hospice, and how can they prepare for them?
I think the biggest is the burden of the physical care of the patient. So because patients don't just need their sheets changed, once a day, generally. So there's the physical care of the patient. There's the emotional toll of having them not eat, get weaker, sleep more. Those are all really, really tough. I think and having their house kind of turned into a hospital room in some ways because of all the equipment you need, the pads for the bed, the urinals, and usually you need to turn a living space, what was a communal living space, like a great room or a living room on the first floor, into the space for the hospice patient in the hospital bed. So the whole environment of the home is changed because you're not in your wonderful bedroom that overlooks the woods or overlooks the ocean on the second floor. You can't, unless you want everybody to be around you, you tend to be in the room that can accommodate the most people. So I think that how much help is needed, how many friends are needed, how much the religious community is needed, and then how much support the family caregivers need. I'm so glad to hear that Steve is a coach for those people and that there is a support for them. Hospice does provide some support, but it's hard. There are things like Caring Bridge, which is a website where people can sign up to bring things. There's just a lot of things to do. You have to assign. I usually tell people, for one thing, to get baby monitors so that there's privacy. You put the baby, you put the one monitor with the patient, and then other people carry the receivers so that the patient can have privacy. So that's very important. But just meals for the family and having someone who is what I call the minister of information, where that person sends all the emails out so that the main caregiver is not spending his or her time all day sending updates and emails and things. But there are websites that are designed for this. You just have to know about it, and hospice can tell you about it, or your oncology team can, where one person once a day can do an update for everybody. But there's a
That's awesome.
lot involved. There is a lot involved in home care of a patient who has a short lifespan, emotionally,
Thank you.
physically involved. Mhm.
Thank you. I don't know if Steve have any other question you want to ask. If not, I will ask the last question. Nope. Steve? Okay, I'll ask the last one. If you could just offer one key piece of advice to a patient or family navigating this decision, what would it be?
Ask for a palliative care consult. Tell your oncologist that you appreciate they don't, everything they're doing for you, and it would be really helpful for them to have a palliative care consult just to check in with the palliative care people. And if the oncologist says, well, you can tell me everything, you don't need to tell the palliative care person, then okay, you've opened up that line of communication. But I would ask for a palliative care consult, at least one.
Awesome. Thank you. Well, that's all the time we had for the discussion part of today. Thank you for all your questions, your participation. And once again, thank you, Dr. Abrams, for sharing your time with us. I will have just a few slides just to wrap up. And I wanted to highlight a great resource for those looking to manage their nutrition and the side effects sometimes of AML treatments and how they can directly impact, such as appetite loss, weight loss, nausea, and fatigue. In January, we hosted a webinar titled Fresh Start 2025 on nutrition side effects for AML care. And we featured two oncology nutrition experts. And in that session, they share practical science-based strategies. So I just recommended you to check it out. I will be sending this link to our registrants, but just so you know, you can access our website and then click here under community, then check our past events. Well, click on community, then all events, then past events, and you will be able to see our past events. So as a reminder, we would appreciate you to take in 2 to 3 minutes to fill out a brief survey. As soon as you try to leave the session, you will be prompted to answer that survey. Mary and I are very excited about the program we've put together for 2025. This year, we've taken your feedback into account to shape the content. So we would appreciate to learn more about what you need from us. Now, our upcoming events. So, genetics is a hot topic today, yet many patients still struggle to truly understand what it truly means for their care. That's why we're bringing in none other than the renowned AML specialist, Dr. Hari Erba, to break it all down. In this session on March 5th, Dr. Elba will help decode the relevance of genetic testing for AML patients, exploring how understanding genetic profile can influence treatment options and improve outcomes. He will simplify complex concepts, so please don't miss this opportunity to gain valuable insights about this topic. We also have some exciting events in the planning process, so watch out in the upcoming newsletter for more information about that. And again, a reminder, we would appreciate you to taking 2 to 3 minutes to the Zoom survey. As always, I would like to thank our sponsors without whom this would have not been possible. So thank you, Avi and Kura Oncology. And of course, thank you all for helping us build AML community. I added my email to the slide, so please do not hesitate to reach out to me. If you just want to say hello, if you want to reach out to me, ask questions about our foundation or anything, I will be happy to help you. I appreciate you all, and I hope you have a great rest of your day. And I hope to see each of you in another webinar soon. So thank you again.
Thank you, Dr.
Thank
Abraham.
you.
Thank you.
Thank you, Dr. Abraham.
Welcome.